Just hang up from that one. You don't get your feedback.
Okay. Andrew saved. Is Jennifer coming back at 8? Is that the plan?
Yeah, Ellie, I was, it's probably going to be brief, so hopefully we're well in time for Jennifer, and even perhaps a bit before. It's always good when there's extra time and people can go to their thing at 8:20. So. So Andrew, are you starting a rock band on the side as well with the long hair? And
Not quite yet.
I think my band is looking for a vocalist and percussionist, so maybe you could join, right? We'll give you a triangle and a microphone.
I'd try out. I love to sing.
Yeah, see how it goes, right? A little bit like when Peter Gabriel left Genesis. So they were auditioning all these people, and Phil Collins would go, it's like, well, no, that's how you should do it. And he would start singing, and the guys were like, and then they auditioned for months, and hundreds of guys, maybe not hundreds, but dozens. Then at the end, the guys were like, you're teaching all these guys how to sing, you should sing. And Collins like, I'm not a singer. And the rest is history. So it's 7:30 now, right? Do we know how many people are joining? Do we see them joining on the screen, or because there's a different sort of login, we don't?
So Mark, we're live now, but we won't see them join. But
okay, so
yeah,
they could be 5 people right now.
Yeah, but they can hear us, so we'll go on mute now, and then I'll just communicate with you over the chat.
It may be around the shift of vocalists of Genesis or Andrew's addition to a rock band, but apart from that, I'll keep it very appropriate.
Perfect.
Okay, Ellie's here, yeah.
Are you okay? You up and running? Because I'm not, so I'll let you go ahead. Okay? All right.
Okay, we're going to start rounds this morning. Thank you for joining. Welcome to Morning Rounds. We have two speakers this morning. The first is our Chief of Surgery, Dr. Ruel, who is now the President of the Canadian Cardiovascular Society. He's going to give us a brief update on the society, and that will be followed by Dr. Jennifer Reed, one of our scientists at the Heart Institute, and she's going to talk about exercise training in atrial fibrillation. So we'll switch over to Dr. Ruel now. Welcome, and we look forward to your update.
Thank you very much, Ali. Let me share those slides. See it now. Pressing the slideshow again. Is this working? You guys can see the slides?
Yes, we can, Mark.
Perfect. Okay, well, good morning. Welcome, everybody. Thanks for joining this Grand Rounds. I want to thank the Grand Rounds team, first and foremost, Ellie and Rob and Peter Liu, as well as our divisional representatives, so Vince, Donna Nicholson, and Hassan Mir, who recently joined from rehab and prevention. It's a great pleasure to be here, and thanks for the foresight of inviting me to present a perspective about the CCS. And this is not really at all about scientific data. It's about what the CCS does and where we'd like to take it as a team over the next 2 years. And I guess the bottom line is, I think it's good for us. I see this as important service. I think it's important service for the Heart Institute. It's important for surgery to have a surgeon once in a while take on this role. It hasn't happened very often. The CCS, as you know, and this is my first slide, is one of the most respected medical societies in the world. Arguably, especially in our field, in cardiology and cardiac surgery and in cardiac anesthesia and rehab, every cardiac patient, at least adult cardiac patient, has this acronym CCS put in his chart at some point, or her chart at some point during the stay or the presentation or consultation. So it is a very, very relevant society, a very trusted one, which has a resonance all around the world. And my colleagues at the AHA and Society of Thoracic Surgeons are all very well aware of what the CCS means. So I think as Canadians, we can be very proud of this society. It's been in existence since 1947. In fact, it started in 1946. With a group of cardiologists from Montreal who decided that their field was important, cardiology, and needed a dedicated medical society in Canada. So they got together, they first founded the Montreal Heart Society, and they had their first meeting in autumn of or spring of 1946. And you can see the agenda for the business session of that meeting. Subsequently, the CCS was created later on. Harold Siegel was one of the key members at the time. The first president was a cardiologist, an EP cardiologist from Montreal, who was Cecil Clifford Burchard. And the first guest presentation was a cardiologist from London, who came in and gave a presentation entitled "Some Aspects of arteriovenous aneurysms. You can see how a little bit different than our current concerns the topic was at the time. So the CCS obviously has evolved tremendously now. It's a huge organization. We actually have 2,500 members. In comparison, in my field of cardiac surgery, the Society of Thoracic Surgeons, which is the largest organization of surgeons in the cardiothoracic field, is about 3,000 members and from all over the world. So for a national organization, it's a huge society, an impactful one from coast to coast. We have, we pay a lot of attention to our leaders. You see here a picture of Paul Armstrong, for instance, and some of the young recruits, some of whom you will recognize. And we also pay attention to diversity, equity, and inclusion. Just no later than 2 days ago, I had a call with Sonia Anand, who I think you will all recognize as a champion in this field. And we got her as my right-hand person, and certainly I will often feel that I'll be her right hand because she's such a content expert in this field to work on the DEI aspects or EDI aspects of the CCS. So when I was vice president, one of the main objectives is we were really working on defining what I would be doing over the next couple of years. And as I like to do, it's always good to be supported by data and by what people actually want to do, rather than this being a monolithic thing arising from the left brain or right brain of some person somewhere. So we really had a thorough strategic definition exercise, if you will, another strat planning. But I think this one was helpful because it will be defining the objectives for my term, my 2-year term as president. So presidents of the CCS are elected for 2 years. Their first vice president for 2 years. That's the true election, which then leads to passage as a president and then past president for a couple of years. Interestingly, from Ottawa, I already stand on the shoulders of much more capable predecessors, Lyle Higginson, really having opened a lot of doors, and you can see CCS is well represented by key players from the Heart Institute, and I think in turn they serve the society really well. And the past president as well from the Heart Institute, the only one of 3 prior surgeons who were president of the CCS was Dr. Keon, our founder, and I think many of you know that. So based on this strat planning exercise, our goals for my term will be the following. And these goals are up front and center. Basically, this is what drives our exec meetings, and we're trying to really have an impact with these 3 goals. I've been in the role for about a month now, a little over a month, and we're really trying hard to achieve these in a tangible way. So some of the goals are easy. They're already having kinetic energy moving forward, if you will, and some of those are more challenging. So essentially the 3 roles are as you see on your slide. First, the CCS is an amazingly recognized brand all over the world. Whether you're in Serbia or in Moscow or in Boston, you know what the CCS means. And we'll use this as the respected brand and its strength to develop and spread excellent practice guidance. And to this end, we have a very strong CPD component, Chi-Ming Chow, who many of you know, very dynamic young leader, as well as Kim Connolly, who requires no introduction, who is now the new chair of our guidelines committee. And Kim and I and many others have worked on really making the guidelines a little less of a mom and pop type of affair, if you will, and have it much more objectivity to it, from the inception, the conception of the idea, the rapid guidelines, the CPU, clinical practice updates. That is the new model that's come in, for which I must thank Andrew Cron's leadership towards making happen. So CCS, we feel, has a role there, especially considering the high number and high prevalence of conflicting and not so high quality information that's out there. The second role is to enhance the membership experience, and I'll touch upon this, and I think that is very important. Every organization is feeling the stretch of membership being less relevant, and we have a number of great ideas and certainly great leadership from Lisa Milichuk at this level. And 3, which is a completely new role, which is something that I take particularly at heart and which reflects our strat planning discussions, is to broaden the CCS role into delving into the cardiovascular health of Canadians. So very much in line with what I believe the Heart Institute does for the region. I often say with a smile that at the Heart Institute, we're everything for everybody. And I think many of us are very proud of that. I think almost every single one of us is proud of this, that we have this role. And I think that the CCS, certainly not to the same depth, but to a wider reach at the level of the nation, could have this role as well. I think just being a member of this organization is something that doesn't get everyone entirely engaged, because I think it can do more, considering that the society is about to celebrate its 75th anniversary and has had an important role nationally and internationally. So I'll speak a little bit more to that. So the first objective, again, in more detail, this is just an example of my colleague, cardiac surgeon, Dr. Mehmet Uz, who mentions here on Twitter, with a huge following, that for centuries we've used astrological signs in order to examine our personalities and how we interact around those, and discover what it can tell you about your health and your outcomes after left main stenting or perhaps heart failure treatment. So obviously this is not what we want people to read. This is not what we want guiding practice right and left. And in contrast, the CCS has a very important guideline process. Many of you would know that we're often at odds, for instance, with the AHA, ACC guidelines. For instance, lipid management is a prime example of this, and that the European Society of Cardiology position and environment does not always correspond to what Canada is. Europe probably has, especially Western Europe, has wonderful care, quality of care penetration. Well, we still have tremendous disparities, and often access and availability of therapies is a huge concern in Canada. So we have to be a little bit more practical than our counterparts in the US and in Europe. Enhancing membership for all constituents is obviously thinking of DEI issues, but also promoting the importance of being a CCS member. I realize that for many of you, renewing your membership is about many things, but also in part about engagement, about supporting the society, about supporting what it represents academically to be a member of CCS, and what it would not if you were not. And I'm very, very thankful for that, for you taking the time to do this. But that being said, we know that young trainees who may be choosing to go into community cardiology or cardiac surgery somewhere, or even or anesthesia colleagues, may not necessarily see the value of being CCS members. And we have a tremendous leader who's with this very, very not so easy portfolio of enhancing membership of the CCS for everybody, who's Lisa Milachak, our very own Lisa, who's working with a strong team in order to examine several ideas around this. I'll give you an example. One idea that also came from the Heart Institute, and we feel that this is one of the reasons why it's good to have some of us there in this organization, right? So Mike Froschel and Marty Green and others who are education experts are proposing the idea that CCS may be very much involved in maintenance of certification for cardiologists and for cardiovascular surgeons, and perhaps cardiovascular cardiac anesthesiologists at some point. This would be a first in the Canadian landscape, and one could easily envision teaming up with the Royal College, where we have strong affinities as well because of who we are, because we're the Heart Institute, and enabling a common platform for maintenance of certification, which would make CCS membership something that every cardiovascular specialist would want to do, because it's a no-brainer and it gives you your MOC credits at the same time. So we're working on that in strong collaboration with the Royal College, and stay tuned, and hopefully this is something we can achieve, or several other achievements around membership over the next couple of years under Lisa's leadership. And finally, perhaps the newest and most far-fetched role over the next couple of years is to increase the societal role of the CCS. As many of you know, I come with a perspective of involvement at the American Heart Association. I love the American Heart Association. I think it's a flower between two ravines. not to use a Beethovenian expression, but it is really that. And the AHA has this huge societal impact, red dress events and Go for Red and etc., which are trying to help with the formidable societal problem of cardiovascular care delivery and primary prevention disparities across the United States. We're not in as bad a situation, but I would argue at the same time that we don't have the data, and we're working on teaming up with our partners such as CIHI in getting, for instance, I'll give you a simple example, SGLT2 inhibitors, Entrestos. I'm convinced that there are many people living away 1 hour, 2 hours, sometimes 6 hours from major urban centers who don't have access to appropriate heart failure treatment. Just to name one example that would be relevant to Ellie and Lisa. And I think the same holds true of many of the therapies that we have available that just don't reach the patient. And this is not a provincial problem. The National Healthcare Act mandates that Canadians should have equal access to healthcare delivery. So I find this very impassionating. Some of you know that we as a division are walking the talk with regards to this. There's huge cardiovascular surgery care delivery issues in Newfoundland, and we're now taking it upon ourselves to help with this problem. So stay tuned. I think the first step, and we're working on this, is to measure some of those examples. You see a picture here of Paul Dorian with Jeanette Petitpas-Taylor, who was the Minister of Health. Previously, this was a quality project. You've all seen the quality indicators reports around PCI, CABG, others. These are procedural quality indicators. They're important, but I want to extend this beyond that. I want to look at less dichotomous outcomes. I want to see, what is the access? If you live in northern Manitoba, where the life expectancy is 50 years old and mostly due to premature cardiovascular disease, what can we do as a society to fix that and work with our industry partners, because they care very much about this, and work with our governments and work with our members, because I know our members care about this role as well, in order to diminish those disparities. So I'll stop here. If you're so interested, the President page was published about a couple of weeks ago, where I outlined these 3 goals for our next 2 years. And I'm really counting on you. The Heart Institute is a national leader, an international leader. We very proud. I know we all are very proud of our institution. It's important that we're there and that we have a national role with our most trusted organizations. So with your assistance and your support, I think we can achieve those goals together. And I'll stop here, and I'll be happy to take any questions.
Thank you very much, Marc, for the update. I do have one question. Given the fact that this year the societal meeting was on a digital platform, what was the feedback regarding that meeting, and what is the vision for the meeting in 2021, COVID pandemic notwithstanding? Let's hope we're in a better place by next October.
No, it's a great question, Ellie. Thank you for that. First, I want to thank everybody for attending the virtual meeting. It's been well beyond my expectations. We have actually had an attendance number of about 2,100. So it's actually above and beyond my most far-fetched dreams of attendance. It's been actually not as much a income generator as the regular CCC would have, but it hasn't been a money-losing proposition. The feedback from the attendees has been mostly very good, not excellent. There were technical glitches, and incidentally, we now have objective data suggesting that most of the glitches, for some reason, again, maybe involvement of the KGB at some point, was involving the surgeons and the CSCS component of the platform, which has been most affected. And I suffered from this as well in left main surgery versus PCI debate, which I was essentially muted the whole time. But overall, a positive experience. And relating to that, the feedback from the organizers, Minister Keon and Keon and Simon Jackson and Anik Ducharme and Shelley Zeroff, who all have tremendous energy, is that they never want to do this again. turn around on a dime in May and organize a virtual meeting for October. So it's very likely, stay tuned, because the official news is not out yet, but it's very likely that the next meeting, which was slated to occur in Quebec City in October, in beautiful Quebec City, will have a very significant, if not an entirely virtual component to it. And that remains the fraction of hybrid versus entirely virtual remains to be defined, and will probably come up, will be fully set in stone around March or so, depending on where we're at with vaccination and the pandemic.
Okay, thank you very much, Dr. Ruel, for joining us this morning and providing us with the update on the society. I know it's played an integral role for all of us during our training along the way, so we look forward to your leadership over the next 2 years. Okay, we're going to move to the next portion of our presentation this morning. Our second speaker this morning is Dr. Jennifer Reed. She's a scientist at the Ottawa Heart Institute in exercise physiology and cardiovascular health, and she's a member of the Division of Cardiac Prevention and Rehab. This morning, Jennifer is going to speak on the role of exercise in managing atrial fibrillation. So welcome, Jennifer, and we look forward to your presentation.
Great, thank you, and good morning to everyone, and thank you very much for having me this morning. Can I just perhaps get it confirmed that you can all hear me?
Yes, we can hear you, and we can see your slides.
Okay, great, wonderful. We're starting off smooth then. As most of you are well aware, atrial fibrillation is characterized by an irregular heart rate and a fast rhythm. Most of you work, or many of you work, in this particular area within the Heart Institute. The prevalence of atrial fibrillation is increasing, and it's particularly higher in those over the age of 80. This figure represents a pooled analysis of individual studies adjusted by sample size and shows the increase in AF prevalence over age. The most recent statistics from a large global survey have identified that approximately 440,000 Canadians are currently living with atrial fibrillation, and this is from a recent publication that's currently in press ahead of print by Day et al. In the European Heart Journal. As you're also likely well aware, symptoms of atrial fibrillation are disabling and they're highly variable, including exercise intolerance, diaphoresis, palpitations, anxiety, dizziness, chest discomfort, acute or chronic heart failure, fatigue, depression, and dyspnea. And all of these symptoms collectively result in a dramatically reduced quality of life. Now, the clinical management of AFib is focused on improving quality of life and reducing symptom burden. And this is primarily achieved through rate control, rhythm control, anticoagulant medications, cardioversion, or procedures including catheter ablation. But with all of these treatment options, reports have indicated that more than 80% of patients with AF report ongoing symptoms that are troubling for them. So where do we look to? What are other options, adjunct alternative therapies? Well, in the past few years, there has been a substantial rise in the number of trials examining the role of exercise in managing atrial fibrillation. And this is really across the AFib spectrum, from those with paroxysmal to permanent atrial fibrillation. And a series of systematic reviews really started to appear in the literature in 2013. Nick Giacomontonio, who's the director of the Cardiac Rehabilitation Center in Halifax, first published a systematic review evaluating the health benefits of exercise in persons living with atrial fibrillation, and largely found exercise to be safe and of benefit for those that had been included in exercise training trials. Similarly, colleagues and I, in 2013, the same issue of CJC, we looked at the chronic effects of exercise training and those only with permanent atrial fibrillation and exercise-only trials. And again, with Giacomontonio showed that exercise training is largely beneficial for those participating in exercise-only interventions. Following these two reviews, in 2014, the first Cochrane systematic review was published looking at exercise-based cardiac rehabilitation, so a lifestyle approach, not only exercise-only trials, but those including other management strategies such as blood pressure, diabetes in terms of blood glucose regulation, obesity management, and stress management that are all part and parcel of exercise-based cardiac rehabilitation programs. We followed with a specific, it seems that we were on track with everyone else in the world looking at exercise training and atrial fibrillation. So my colleagues and I also published a systematic review specific though to cardiac rehab in patients with AF in the Canadian Journal of Cardiology. It was a larger systematic review than the one that was published before. And this just speaks to the volumes of research that's been done over the past few years of original trials examining the impact of exercise training in those with atrial fibrillation. And most recently in 2018, Smart and colleagues published a systematic review examining exercise-based cardiac rehab, including systematic review and meta-analysis of randomized and non-randomized trials. What have these reviews shown collectively with all of the original data that's been published to date? Well, we have seen that exercise training and exercise training as part of cardiac rehabilitation programs leads to improvements in peak aerobic power, otherwise known as cardiorespiratory fitness, functional capacity, often measured by a 6-minute walk test, strength, power, activities of daily living, quality of life, cardiac function as denoted by improvements in left ventricular ejection fraction and lower resting and submaximal exercise heart rates and symptoms. As a result of the information that had been growing in the literature regarding exercise training in those with AF, my colleagues and I, you'll recognize the other names here that will be known to you within the walls of the Heart Institute. We decided to put together a very practical article on exercise training for patients with AF. And we did this in the form of a practice article in the Canadian Medical Association Journal in 2014. We put together what we called the 5 things to know about exercise training in AF. And in this 1 to 2 page handout that was published, we included our FIT approach for AF, and FIT stands for frequency, intensity, time, and type. We recommended patients exercise at least 3 days a week at a moderate intensity, although we provided objective criteria. Using heart rates alone to prescribe intensity is not the most ideal method given the irregularities in heart rate. So we recommended the alternative being the talk test, in that if patients could exercise at an intensity that permits simple conversation or the ability to hum or sing a tune, that is preferable at an intensity. Time, at least 60 minutes per session. And again, for patients that would be deconditioned, we recommend working up to a duration of 60 minutes or more, and activities that use large muscle groups. This collective document was based on original trials that had been published, included in the previous systematic review, so in line with the literature at that time. And our recommendations also aligned with the Canadian Association of Cardiovascular Prevention and Rehabilitation exercise recommendations for all patients with heart disease. They recommend patients exercise most days of the week at a moderate to vigorous intensity, that being 40 to 85% of heart rate reserve, if using heart rate as an objective tool to quantify exercise intensity. Time, including a 60-minute exercise duration with a warm-up and cool down. The majority component of the conditioning would be 20 to 40 minutes at a moderate to vigorous intensity. And type, including both aerobic, using large muscle groups, and resistance training activities. Until recently, none of the clinical management guidelines for AF across the world included exercise training or a discussion of physical activity. Recently, the ESC has included the recommendation of physical activity for patients with AF. And just the other month, the Canadian Journal of Cardiology published the 2020 CCS and Canadian Heart Rhythm Society comprehensive guidelines for the management of AF. These are the first guidelines to provide very specific recommendations regarding exercise training. So while the ECS provided recommendations, they weren't specific in terms of the FIT principles. So I've provided here these most recent guidelines that are currently in press. And if we zoom in on the exercise training portion, first, as part of the care plan for patients with AF, they're specifically recommending that exercise physiology be included in the multidisciplinary team. For exercise, they're recommending moderate intensity aerobic exercise, at least 30 minutes a day, at least 3 to 5 days per week, targeting at least 200 minutes weekly. They're also recommending resistance exercise 2 to 3 days per week and flexibility exercises in those over the age of 65. I think it's important to note here that it is absolutely wonderful to see these guidelines reflect the growing literature regarding exercise training and the improvements in both physical and mental health that's been observed in response to the testing of exercise interventions in this population. These guidelines, the values provided are a bit different than what you see in terms of the most recent Canadian Physical Activity Guidelines and the World Health Organization guidelines that recommend 150 minutes. These are also higher than any cardiovascular prevention disease guidelines that exist across the world. And if you look deep into the guidelines, you'll find that the few sentences regarding exercise actually focus on athletes or those at risk of AF or post-procedure. They do not include a discussion of those with atrial fibrillation. And if you look to the studies that have included those with AF, whether paroxysmal or to the end permanent AF, you'll see that these targets and recommendations do not necessarily reflect what's been included in those studies. So not to minimize by any means the importance of having exercise in the guidelines, I think as a clinician, when you are meeting with patients, it's pertinent to think that all patients will need to begin with a much lower volume. Of course, more is always better when it comes to physical activity, and we've seen in recent trials there is no upper threshold. So it's progression that will be key, and the resistance training and flexibility exercises that have been included are wonderful and do align with WHO and Canadian Physical Activity Guidelines, but we haven't seen this specific literature in the AF show the benefits of these particular exercises or been included in prior trials. So with that in mind, we decided a few years ago to dig a bit deeper into the role that cardiac rehabilitation programs could play with managing patients with AF. And as you're well aware, cardiac rehabilitation programs exist across the country and have large resources and infrastructure behind them in terms of managing many patient populations with heart disease. So we wanted to address or test the role of our cardiac rehabilitation program in managing patients with AF, given the high burden associated with these patients. So we conducted a case control study, total of 94 patients, 47 patients with heart disease without AF, and 47 patients with heart disease with AF, a case control study. All patients underwent a 12-week cardiac rehabilitation program, including structured exercise training, risk factor assessment and management, and access to support services. These support services included smoking cessation, vocational counseling, nutritional counseling, and psychosocial counseling. We specifically focused on mental health. Quality of life was assessed by the SF-36, which is a general health evaluation scale, and mental health assessed by the hospital anxiety and depression scale. And what we found is that energy, emotional well-being, social functioning, and pain, as assessed by the SF-36, we saw significantly and clinically significant improvements in these scales in those with heart disease without AF. So the patients without AF benefited to a greater extent with regards to quality of life than those with AF. The same for the physical component and mental component summary, where we observed statistical and clinical improvements in patients with heart disease without AF. We did not observe any differences between patients with and without AF with regards to cardiovascular health indicators, specifically body mass index, waist circumference, and blood pressure. Our results highlight that cardiac rehabilitation programs, which have existed for decades and are well known for improving many cardiovascular health indicators, continue to do so but they perhaps are not as aggressive or intensive enough to meet the demands or the needs, specific needs of patients with atrial fibrillation. They do without question address the needs of patients with heart disease in general, but whether they specifically target the needs and the symptoms associated with AF is not what we found in this particular study when assessed by these tools. So I'm going to switch gears for the rest of the presentation to focus on high intensity interval training, an area that you may be aware of from your readings or from the media. High intensity interval training is not a new exercise paradigm by any means. It has existed back to the times of the ancient Greeks training for the Olympics. In brief, high intensity interval training is an alternating workout. It consists of vigorous periods of exercise for short duration of time, followed by recovery periods. And this on and off of a high and low is what really constitutes a bout of high intensity interval training. Many perceive it to be effective, but also efficient, that these bouts of exercise typically are much shorter in duration than other forms of moderate to vigorous continuous exercise. One of the most well-known protocols that exists in the literature is called the Norwegian Protocol, the 4x4. It includes a warm-up and cool-down, but really the meat or the bulk of this exercise paradigm includes 4 high-intensity intervals at 85 to 95% of peak heart rate, and 3 recovery intervals at 60 to 70% of peak heart rate, for an overall exercise duration of about 45 minutes or less, depending on the length of the warm-up and cool-down. There have been a plethora of studies comparing high-intensity interval training compared to moderate intensity continuous exercise training, known as MIT or MICE, which is standard care for cardiac rehabilitation programs for patients with coronary artery disease, heart failure, and other cardiovascular conditions. And one after another, systematic reviews, including original studies, have shown that HIIT is superior than MICE when it comes to improving cardiorespiratory fitness, reducing resting and submaximal heart rates, blood pressures, blood lipid profiles, fasting glucose levels, mental health, quality of life, and motivation to exercise. Given the literature that, again, has been rising over the past 10 plus years regarding interval training in patients with heart disease, my colleagues and I decided to pursue a case study to examine the impact of high intensity interval training. We didn't use the specific Norwegian protocol, but we did use another very short duration high intensity interval training protocol. And we examined the impact of 3 HIIT sessions per week for 10 weeks on a patient with permanent AF. This was a male patient who was 70 years of age, who was obese, also pre-diabetic. And again, this is a case study, so an N of 1, so we have to take the quality of such trials into consideration. But what we did observe is that this patient achieved substantial improvements in blood pressure, 6-minute walk test distance as measured by a walking test, functional capacity, and AF-specific quality of life. These improvements were substantially greater than those typically observed with MICE or MICT studies. Again, an N of 1, but promising, encouraging results for this particular patient who had suffered from AF for many years. One of the landmark trials that's been published to date regarding interval training in patients with AF is a randomized control trial published by Malmo in Circulation in 2016. They used the Norwegian Protocol in patients with non-permanent AF and showed that 12 weeks of high-intensity interval training in non-permanent AF patients showed an increase in time in AF in the control group, approximately 4%, and a decrease in time in AF in the exercise group. The first trial to show an impact of exercise training, particularly high-intensity interval training, on time in AF in a non-permanent AF group. Many Many investigators have explored the mechanisms. Why is high intensity interval training beneficial to patients with AF? What are the specific mechanisms that we're leveraging here to generate improvements, whether it be in AF specific symptoms or quality of life, cardiorespiratory fitness, or other cardiovascular health parameters? And these studies have spanned from looking at AF burden, symptom severity, and also potential mechanisms have included reversal of atrial remodeling, weight loss, improvements in blood pressure, glycemic control, reduced inflammation, and the one that probably receives the most attention in the literature is improvements in autonomic tone, such that there's improvements in parasympathetic function that potentially leads to reductions in resting and submaximal exercise heart rates. That may contribute to some of the improvements that are observed or felt by patients with AF. There's still much more to be done in this area. This was an article published in Circulation 2016. So you can just see the impact of some of this work that's landing in some of these high impact journals. So my team and I and colleagues have been quite busy over the past few years. We have been fortunate and received funding from a few organizations looking at the impacts of high intensity interval training in patients with AF. We're trying to drill down into some of the mechanisms, but we're also particularly interested in the impact of high intensity interval training on physical and mental health in patients with AF. This is the first trial called Opportunity. It was funded first by AFP with Dr. Gira Schneer, followed by an early research emerging initiatives award I received from the Heart and Stroke Foundation, and then later also funding received through a CIHR New Investigator Salary Award. I'm excited to say that we recently finished this trial right before COVID hit. Actually, we were just finishing up some of our measures. So the beginning of COVID, we were able to just finish the last little bit of this trial. And now we're underway with data cleaning and analysis. We recruited a total of 86 patients, or 86 patients, I should say, were randomized to either mice or HIT. And you can see in the blue boxes the dropout rates. That's the data that I've provided to date, but we have completion data and dropout rates. So we're seeing dropout rates of 13% in the mice group and 7% in the HIT group. And, you know, without having actual data to show you today, more to give you an idea of what we're working on. But I will say from personal experience of my team and working with these patients that with our HIT sessions, the compliance and adherence to the exercise protocol was simply very interesting and amazing. It would be snowing and blowing outside and roads would be closed, but patients would still find a way to get to the Heart Institute for these HIT sessions. I believe our compliance numbers show that approximately 98% of exercise training sessions were completed for the HIT group in comparison to our mice group. So whether this is a factor of time, the mice group having a substantial longer exercise session, or simply the modality and the enjoyment or motivation factor, that's yet to be determined, but stay tuned for findings from the Opportunity trial. So in addition to this trial, we are also in the middle of finishing up, or I should say midway now with COVID, our Exercise AF trial, and this was funded by a much larger initiative through CIHR project scheme. And so this is a larger RCT, which includes standard of care. And what I didn't specifically mention in the previous slide with Opportunity is that we were comparing cardiac rehab really to high intensity interval training. In this particular trial, both exercise groups are on a bike, and we've standardized the intervention to a much greater extent. So the exact same modality, but the intensity and the time is different, where in the previous trial Opportunity, it includes cardiac rehab, so the modalities are quite different. It's a typical cardiac rehab setup, so a little bit less standardized than the approach we're taking with Exercise AF. And so this is my plea to everyone who is involved in caring for patients with AF. If you have any patients with persistent or permanent AF, we are looking for all comers. And my pitch is that we are one of the only exercise facilities that are open that are offering a safe one-on-one exercise training session for free at the Heart Institute for this trial. So if you have patients with AF, please reach out and refer, and we can provide them all of the pertinent information. Particularly females. We are also really wanting to do our due diligence and including as many females as possible with this trial. So just a few slides to really go over the physical activity levels of AF patients. We focus so much on, or we have focused substantially on exercise interventions and what is the role or the impact of exercise on mental and physical health with patients with AF. But what do we really know about their actual day-to-day habitual physical activity levels? And so this trial by Chang et al. Published in 2012 was a global survey of over 26 countries, nearly 10,000 patients, and examined the risk profile of patients with AF. And what they published using a very crude measure of physical activity, a yes or no response, is that if we look across all AF subtypes, we find physical inactivity rates between 53 and 65% in the AF population. Not surprising, this would be in line with physical activity guidelines. In fact, with the Canadian physical activity guidelines, we find as low as 15% of Canadians are meeting such guidelines. But that's when we assess physical activity using device measures. In this case, it's self-reported, and we typically see more desirable numbers with self-reported because there is risk of bias and recall bias as well. Just recently, this year, the first to objectively measure physical activity levels of patients with AF using wearable fitness trackers. And Seaman and colleagues have showed that patients with AF, when adjusted for baseline characteristics and medical conditions, do take fewer steps on average than those without AF, approximately 600 steps showing here in the adjusted model. Now, whether this is clinically significant, it's really hard to know at this point, but it's simply an observation study reporting on physical activity levels in the form of step counts. Whether this translates to other health conditions within this patient population, it wasn't particularly the focus of this study. So before I leave you today, I just want to finish off with two final slides to let you know of some of the work that's been completed by one of our postdoctoral research fellows that's recently finished with us and now holds a tenure track position at Deakin University, and that's Dr. Kimberly Way. She was recruited to lead the Champlain AF trial, and so we recruited 800 patients across the Champlain region with much help from our colleagues, Dr. Burney and others, in recruiting these patients with all forms of AF. It's an observational trial assessing physical activity levels, but we also really wanted to drill down into the behaviors of these patients regarding physical activity. And when I say behaviors, I'm specifically referring to the knowledge, self-efficacy, and outcome expectations regarding physical activity. It's one thing to assess the physical activity levels, but some of the drivers behind that behavior is really important to understand when we start to make recommendations regarding lifestyle changes. So I'm just going to show you a snippet here, 3 questions that are pulled from a very large survey. All these patients were verified to have AF in EPIC. We pulled all of their medical information from EPIC and clinical charts as well. So we feel this is one of the true strengths of this study, is it's an observational study, but we have pulled all of their health information from actual medical records. It's not simply reported through online processes for an observational study. So the 3 questions I'm going to share with you today are, and this was asked of the patients that participated: has a healthcare professional spoken to you about engaging in physical activity to manage your AF? And the majority of patients reported no. How important do you think physical activity is for managing your AF? The majority of participants reported important or very important. And last is, my AF would improve if I was physically active. This was close between the disagree and agree categories, but predominantly most reported agree or strongly agree, excuse me. So you can see that most patients believe that physical activity is important for managing their AF, but they haven't had these discussions with healthcare providers. And these are only 3 questions of a much larger survey, but what we are reporting overall is very low physical activity levels in the AF population. So you'll have to stay tuned for our Champlain AF results. We have the manuscript drafted and co-authors have reviewed. So now it's to us to finalize the edits and get this submitted. So with that, I will say thank you for the invitation. Again, it's the first time I've presented at Cardiology Rounds in the morning, so it was a pleasure to accept the opportunity. And I'll open it here for questions, if that's okay.
That's great, Jennifer. Thank you very much. We We were looking forward to your talk today. I do have a couple questions. One is from Dr. Liu, and it's a bit more of a practical question, and maybe he's going to take some of this to advice, because I see him jogging around the neighborhood during the summertime. But his question is, do you have practical tips for patients to maintain exercise programs during our long Canadian winters, and particularly now when a lot of the gym facilities are closed?
So great question. We are just actually wrapping up a large review article focused on home-based exercise during the COVID era for patients with heart disease. And we've decided to make it very, very practical. So within this review paper that we soon plan to submit to the British Journal of Sports Medicine, we have included very specific recommendations for exercise at home. We've provided exercise training progression plans. We've provided links to videos, so everything they would need to be active on their own, as well as resources that clinicians can use when counseling patients that they see. So that is something we will absolutely make available to the Heart Institute as well, because we do feel that having these really practical suggestions is key, because we all know we should be active, but how are we active during a pandemic when the facilities are closed and during long Canadian winters is a very important question. And I think we can't just say be active. We have to do much more than that. We have to really provide the very specific details in order to help patients with ideas and tools to be active.
And I actually have a question regarding resistance training. So you've kind of talked or outlined activities that are encouraged. Are there activities that are discouraged? Because I have some patients that would prefer to participate in very heavy weightlifting, which I have discouraged actually, but I'm just wondering what the science sort of says about this.
Yeah, what I would suggest is for any patient starting off that they really do start off with low to medium weights for resistance training. There are definitely very well-published benefits of regular resistance training, and those benefits are above and beyond what moderate intensity or vigorous intensity affords, and that's specifically related to bone health. So reducing our risk for fracture and falls is really important to consider, and why we should be promoting resistance training and flexibility training as well. But for patients that are just starting off, or those that have had a cardiovascular event, starting off with low weights and gradually increasing is the safest approach for them, both from a technique and injury point of view, but also that we don't want to create an unnecessary high load on their cardiovascular system without some adaptation prior to that.
And so similarly in that line, if you have a patient who prior to presenting to you was a weightlifter, and a lot of us have some of these folks in our clinic, kind of the gym junkies, so to speak, who's in there trying to bench 250 but do 2 reps. I presume the recommendation is to stop that type of activity, because that's certainly what I have been telling my patients with hypertension, heart failure, etc., just because of an afterload increase.
Yeah, one of the things that's recommended is we can do a 1 rep max test, and so that's to first identify what load they could lift. And then we prescribe a percentage, and that's typically the route that most physios or exercise physiologists would take, in that we first need to establish what their high value is. And once we know that, then we start to prescribe at 50% or 60%, and it's a gradual workup. So even though they could lift, let's say, I'm going to throw a number out there, 200 pounds prior to their event, could be much higher, could be much lower, but we never want to start them close to that value after an event. So although the rest of their body may be conditioned in terms of their arms and legs, right, that is not necessarily where the injury has occurred. Of course, it's been a cardiovascular injury. So they may feel absolutely fine with regards to, muscle tone with other areas and feel ready to get back into it. But I think just prescribing based on a percentage over time is what's recommended. And the resistance training piece is really key for them to keep up. There's lots of literature showing the benefits of resistance training within CVD populations. So we don't want to persuade them away from being, regularly engaged in resistance training, but it's all about progression and knowing the limits, especially within the first few weeks or 2 months after an event, because the afterload is absolutely a concern. And also proper breathing techniques typically go into the kind of retraining after. We want to avoid the techniques of the Valsalva, right, when they're holding and creating more pressure. So they may not be aware of that prior to their event, but after, those are some of the really simple techniques we need to ensure are followed so that we can reduce any chance of further injury.
And I have one more question from Dr. Beanlands. Which patients would you recommend that we send for the exercise programs? Is there anyone that, or maybe a better way to phrase it is there anyone that we should not send to the exercise program?
So I was going to say he's probably referring to the AFib patients. Send everyone. So we'll make it really easy. You just send them our way, and then we'll do the appropriate screening to determine whether they meet the inclusion-exclusion criteria. If he wants to see the inclusion-exclusion criteria first, we can happily send that as well. Whatever is the least amount of work on his part, but generates the most number of referrals is what we're looking for.
And so do we, just to help facilitate recruitment to your study, should we refer them just through rehab, or do you want people to contact you directly?
It's easier
to facilitate that.
Yeah, it's easier to contact me directly. They can get lost sometimes through the rehab channels if rehab is not aware of the specific trials going on. So if I just get an email that says a name and an MRN number, that's really all I need. I pass that on to the coordinator. They verify they have been approved to be contacted for research, and then they start the process. So oftentimes from the EP group, I just get name or MRN number and we go from there.
Okay, excellent. Well, hopefully this will improve your recruitment.
I hope my plea was encouraging. Help us.
All right. Well, thank you very much for joining us this morning. We have come to the end of our hour, so I'd like to thank everyone for joining us for rounds this morning, and thank Dr. Reed and Dr. Ruel for presenting. We do not have rounds next week as we're entering the holiday period. We will resume in the new year, and we actually starting with grand rounds on January the 6th. And I believe we have an international speaker, Dr. Spurtis, joining us. So have a happy and healthy holiday season, and we'll see everyone in the new year. Have a great day.